that they're using. And so addressing the opiate use issue is not adequate in itself. And I think most of us know about motivational interviewing and 12-step facilitation therapy. But these are some principles of addictions treatment that I thought would be worth discussing. And so I'm just going to progress through each of these different items and talk about the relevance to addictions treatment. So the first one is finding leverage. And what I mean by that is you want to find something that impels the patient to change their addictive behavior, to work on recovery and live a different life. And so what I often do, and I think other clinicians do this as well, is when a patient first presents to the COAT clinic, you want to know what brings them to treatment. You know, why do they want help? What are they doing here? And so often you'll find the leverage that impels them to want to improve their lives. And so if you don't have leverage, then not much is going to change. And it can be family issues or children problems or legal issues or medical problems or financial issues, or there can be a number of reasons why they're motivated to change their behavior. And so you want to have that present to try to change this the behavior. Any questions about that? All right, so the next principle is to intensify the level of care if failing the current level of care. And basically the point here is that patients learn from the system that you operate that if they're failing the current level of care, they're going to be required to be involved in more attendance at the program. They may be hospitalized or in a rehab. So they realize there's more time commitment on their part if they're not working on their recovery. And also you're offering them more treatment if they're failing the level of care that they're in. So you're accomplishing two things with this process. And I think it's nice in the COAT program that we have here at WVU that within the COAT program, there's levels of care and how intense the treatment is. And when patients do well, they come here less and less often. And when they're not doing well, we intensify the treatment. So that's an important component of a good recovery program. Any questions about that? All right, the next concept is social group reconstruction. And basically what this is about is the recovery environment that a patient is in. And if their social group is a negative group of people who are leading unhealthy lives and tempting them to use substances and doing other self-destructive behaviors, it's kind of contagious, and that's going to affect the quality of their lives, their success with recovery. And so an important part of addictions treatment is this social group reconstruction, where patients actually find other social groups to associate with, and they can meet those people at support group meetings, but they might find it at an employer, you know, at their employment. It might happen in school where they meet people who are living healthier lives. They may volunteer in some capacity and find a social group that way. And so there's lots of different things that patients can do to kind of recreate a healthier social group. The next concept is from cognitive behavioral therapy approaches to addictions treatment. And basically you want to think about, you know, what are the high risk situations for relapse for a patient, and how can we prepare them for it so they can have some experiences of being successful turning down a substance in a high risk situation. And so when patients present to the group meetings that I have, if they slipped and they used something, we explore what was the situation, why was it risky for them, and they succumbed to the use of the substance, and how could they prepare for that in the future so that they could avoid using a substance under the same circumstances. And so the more prepared a patient is for the toughest situations, everything else is so much easier. So it's an important concept in treating addictions. And that comes from the cognitive behavioral paradigm. And then the next one is from AA and NA. And there's a couple of terms, a couple phrases they use: play the tape through and think through the drink. And so there aren't many recorded tapes that people use anymore for music, but the tape they're talking about is to play the whole tape through of the situation of using a substance. So if a person is going to use crack cocaine, then that's going to lead to an escalation of crack cocaine use, and then they'll go into a terrible crash after they use it, and they'll have financial problems, and they may get into legal trouble. It'll affect their family. So they're kind of thinking through the situation to the consequences and the consequences of the consequences and the unintended consequences. And so I like to use these terms, play the tape through with patients as a way of kind of conceptualizing this idea. You got to think it through to the consequences. And that can often be a motivator. If they do that during a high risk situation, that can help them remain sober. And then there's a literature about refusal skills. So this is stronger literature for the adolescent population, but I think it applies to patients at all ages to develop refusal skills for if somebody offers them a substance, how are they going to turn it down? And so if they have the words kind of prepared in advance of what they will say, then it just kind of comes right out of them easily. And if they haven't thought it through and they haven't kind of worked out what their refusal approach will be, they're more vulnerable to the pressure, the social pressure of the situation, or the awkwardness of the situation. And so what I tell patients often is to say something like, no thanks, I'm trying to take care of myself. And I think by saying that they're trying to take care of themselves, it gives them the message, don't offer this stuff to me. I'm trying to live a different life. And so they have a firm way of turning things down. And when you talk to patients, some of them use very strong language, F no, and they may really talk strongly with people about refusing offers to use substances. But I think that they got to work out in their minds, what they're going to say to get some experiences turning down the substances. And after they have a couple experiences being successful, they're like crucibles of experience that carry on for the rest of their lives, where they have learned that they can do this. And that's when a nice recovery program really gets going. The next concept is something I call same plan, same result. And so patients will talk about what their plans are for abstinence and what they're going to do with their lives, and how what kind of recovery program they're going to work, and what kind of treatment they're going to get involved in. And so it's important to think, well, has this worked for you in the past? How much sober time have they had in the past? And what helped them maintain a period of sobriety? And if that plan worked for them then, it's likely to work again now. So you want to think about it. It goes kind of in both directions. So if they've had a period of sobriety and success at that plan's likely to work. If they had a plan and they failed and they relapsed or things escalated, that plan is likely to give them the same result as well. And so this concept of same plan, same result is really important in kind of educating patients about thinking, do I need a different plan? Or, am I trying to repeat the same behavior over and again and expecting a different result? The next concept is surrendering. And basically what I'm talking about is that when patients are using substances, the case with the patient using methamphetamine, I think it boils down to a surrendering where they finally just kind of accept that this doesn't work for them. The substance use isn't working for them in their lives, and it just isn't an option. And it is kind of a surrendering. And you hear about powerlessness in AA and NA, and I think this is kind of what they're getting at. That it's a surrendering to the idea that it's just not an option, and that life doesn't work for them. And once they kind of surrender, then it opens them up to living differently. And when patients think they can control their use and they haven't kind of surrendered, that's when they get stuck in a pattern of use. And then I guess I'm preaching to the choir with concurrent psychiatric care. But there's several things about psychiatric care patients with substance use disorders. And it used to be that they thought that you had to treat the substance use disorder first, And then once they were stable, you could address the psychiatric issues to be sure that it wasn't a substance-induced psychiatric disorder. But I think we know pretty clearly now that psychiatric care should be concurrent with substance use treatment. And I'm sure you've heard of the self-medication hypothesis. But patients who are in psychological distress because of psychiatric disorders may be trying to palliate their psychological distress with a street drug or alcohol. And so if you address a psychiatric condition, this kind of frees them up to change their addiction behavior. And then things like ADHD, there's evidence that untreated ADHD, the impulsivity leads to more substance use. So getting an ADHD disordered individual treatment of ADHD can reduce substance use and it has a better prognosis. So there's several ways of looking at psychiatric care of patients with substance use disorders. And you definitely want to identify when that's an issue and facilitate them getting treatment. And then the last concept that I want to talk about is, this is kind of my own wording, but is building a strong stress recovery self-efficacy. And so I often find myself talking with patients about stress, and they'll complain about how their lives are so difficult and stressful, and they use substances to feel better because they're under so much stress. And so a couple things that I do to kind of approach this. First of all, I believe in stress inoculation. And what the principle of stress inoculation basically says is that stress is like a flu shot. And so somebody gets the flu shot and then they fight off the virus in the flu shot. And then when they're exposed to the flu, they're resistant to it. And stress is the same way. When somebody is exposed to a stressful situation, it's miserable and difficult and they can't stand the situation, but they get through it. And then when a new situation comes up, they're like, oh, that's not so bad. I've been through so much. And so and people don't realize, they don't look at their stressful situations as kind of making them stronger or more resilient. And so it's a reframing of the stressful experience, and it empowers them in their stressful experiences. And this even applies to PTSD. If a patient's had a terrible trauma, you say, trauma's never good. And but if you can look back at a trauma and say, if I could survive that, I could survive almost anything. And then when new situations come up, you're like, that's not so bad because I've been through so much. So that's called stress inoculation. And there's lots of ways that people can recover from stress. And many patients with substance use disorders use substances as a way of dealing with stress in a self-destructive pattern that escalates the stress because of all the life circumstances that are caused, worsened by the substance use. And so you want to help them develop a stress recovery plan, or an unwinding routine to de-escalate from stress. And so there's psychological things like optimism and humor and self-assertion and social connections and social support, and spiritual life can be supportive, and physical things like stretching and physical exercise. There's many ways that people can recover from stress, but the important thing is that they get self-efficacy about it. So self-efficacy means that they're confident, they believe in themselves, that they can successfully calm down from a stressful situation and recover. And stress recovery has been shown to be important in medical outcomes. It's important in the exacerbation of psychiatric illness, and it's important in longevity, like the telomere length that determines how long someone will live. Telomeres are like the aglets on the end of shoelaces, and they're long initially on the end of the DNA, and then they shorten with stress and other aspects of life. And so having a good stress recovery self-efficacy is going to prolong life because it's not shortening the telomeres. So basically that's what I wanted to talk about. Do you guys have any other ideas about interventions for addictions that you suggest?
Dr. Hirschler, I love that you included the last one on there, the number 10 point. I think good programs really cover the top 9 and sometimes forget the importance of talking about the number 10 one, because sometimes we're the healthiest people in their life that they know. They're not gonna be able to go home and really develop 10 on their own, that they need our help in doing that. So I love that you included that.
Yeah, it's important. And when patients, are able to kind of soothe themselves, self-soothing, it's a valuable skill to have because life is stressful.
Mm-hmm.
This is Bill in Charleston. One of the things that I'm trying to do right now is to kind of neutralize the spiritual language of the 12 steps and look at more common language that's acceptable to those patients who have problems agreeing with it, with God language and so forth. I mean, for example, step 3, instead of using higher power, a commitment to change, commitment to finding a better way of living. So those are some of the things that, I'm going to at least see what happens with that. That's not something that I've invented. There's an author, Alan Berger, who wrote 12 Stupid Things to Mess Up Recovery. Some of you probably heard of, and he talks about the principles behind the 12 steps.
I love that.
That's great. That's also a good reminder. Caitlin should have, and she did send out a link for a webinar tomorrow that goes over the body of evidence supporting 12-step programming for addiction recovery. And I think it's really, really important for folks to check that out, and so that they could get a sense of what does the literature actually say out there and how valuable this can be.
I completely agree, and for those people who can accept it, I think the peer support is very important. I'm just hoping that some of them can carry a different ear into the meetings who have trouble accepting the God language.
Yeah.
See, a lot of times they come around anyway, but makes it.
When I talk to patients about mutual support groups, I try to emphasize the value of meeting somebody who has a story a lot like theirs, but has been successful and has a number of years of sobriety. It's inspiring for them, and so meeting somebody like that, and then getting their phone number, so in a time of crisis or difficulty, they can give them a call and get some support. And so I kind of take the attitude of eat the meat and spit out the bones. Just take what's valuable and disregard the part that you don't necessarily agree with.
Yeah, I agree with that. They a lot of times they say take what you need and leave the rest. The whole thing. A lot of times you hear people say that the 12-step recovery rooms is the first place they felt comfortable. They felt they belonged there.
Yeah.
Awesome. Thank you all. Thank you, Dr. Hirschler, for your presentation.
Yeah, thank you.
And thank you, everybody, for your participation. Our next session, I will have to look at it and let you guys know what we have planned for that. But I know we have some stuff coming up. It's on May 13th is our next one. And then I wanted to let you guys know that I actually started a YouTube channel for all of the didactics I've been recording. So you guys are able to go back and watch the ones that if you missed a session or something like that.
That's cool.
It's just West Virginia Project Echo. You can also see the other ones if you're interested in the chronic pain or anything else that goes on.
Thank you for doing that.
Yeah, no problem.
Cool.
All right, guys. You have a wonderful Monday.
Thank you.
Thank you.
Bye.
Thank you.
Thank you, Caitlin.
Yeah, thank you all.